Excellent. Well, thank you so much, everybody, for joining us. Whether you're watching live or on the recorded version, we're really happy that you found us and are here to learn more about a different form of seizure control that I think a lot of us maybe have heard about, but maybe don't know a lot about. And I'm super excited about our panel today. First, I'm going to introduce our caregiver voice. And today we have Wendy Sunahara, whose daughter Shae has tuberous sclerosis complex, and she's 19 years old. And she's going to share a bit about her experience with these different forms of, I don't know, what do you call not stimulants? What's the best word I should use here? Anyway, so let me.
Is that what you mean?
What is that?
Stimulators? Brain stimulators?
Stimulators, is that okay? I wasn't sure exactly if there's like lingo for it because I'm learning too, obviously. So
no issues.
All right, so I'm just going to pull up this slide because we are lucky to have a visual as well with Wendy's presentation. So, all right, Wendy, you're up.
All right. Well, thank you for inviting me. You know, this is my very first webinar, but I'm really honored to be a part of this panel of experts. Just very fond of all of the work that's being done and so much of the opportunities that Shae has had. Shae is 19. She was diagnosed at 3 months of age with tuberous sclerosis complex. She also has autism, epilepsy, and intellectual disability. She's probably functions about at the age of a developmental age of 2 to 3. So she is reliant on me for her constant care. I still do all of her bathing, everything like that. But we are very thankful because she is completely ambulatory and she feeds herself, and there's so many other things that she does. She's mostly nonverbal, but she does have a few words. She can't converse, but she can see something and tell me, you know, that she wants it and so forth. So she has intent and she has a little bit of language. So there are a lot of positives there too. And the slide you see of her there is, we just went to Cancun and she loves the sensory of being in the water and the sand and so forth. So that was just heaven to her. And it's really nice to see her just have her freedom and be a regular teenager too. But so she started at 3 months of age having seizures. They were mainly focal seizures, and her seizures through the years have evolved. She's had many different types. She has had infantile spasms when she was about 7 months of age. And we've been very fortunate along the way. The majority of her care is done at UCLA, and we've had some phenomenal doctors, Dr. Wu especially. And so Shae has participated in a number of studies. She was on vigabatrin or Sabril to stop the infantile spasms. And we have tried Epidiolex, the CBD oil. We've tried almost everything to stop Shae's seizures. She has had 3 separate resective neurosurgeries, and she has improved with each one, but we just have never been able to get a complete handle on her seizures. We finally decided that we would try the VNS, and she has had that in for about 4 years now. She has gotten improvement with that. That was a very simple decision to make. It really was a very simple surgery. Maybe I think it was about an hour or two. The care was mainly just caring for the wound and learning to use the magnet, and then just the stages of programming just to find a good setting for her. And it definitely has helped. I was looking for something other than more meds, because Shae has always been on a cocktail of meds. I really have always told myself I would love to see what the real Shae is like, because she's very slow moving. She has been lethargic at times and drowsy and sleeps through the day. So to try something that was not more medication was my goal for her. We tried the VNS, and then that helped somewhat. But for Shae, it still required quite a bit of medication along with that. And as her seizures evolved, she was primarily having tonic and generalized tonic-clonics. She was regressing a little bit, and through video EEG, we found that she was having tons of seizures through her sleep. So while we were not seeing them visibly through the day, she was having them all night. And we even did a sleep study and found that she only got through stages 1 and 2 of sleep and never got to stages 3 and 4. So it wasn't a wonder shortly after that we decided what else could we try. And that was when CBD oil was starting to make its self known in the market, and everybody was interested to see how that might help with a smaller side effect, or very little side effect. I was excited that we could get her in a study for that at UCLA. And that also did help her. It helped her seizures, but unfortunately for Shae, it interacted with some of her medications. I think the big one was Onfi or clobazam, and that interaction just left her. We had some better control of the seizures, but it left her sedated. She just was spending the day sitting on the couch sleeping. And I thought at that point, my goal was no longer just trying to gain seizure control, but it was quality of life for Shae, because spending, even if you have some better seizure control, spending your life just sleeping is nothing. And she would drool and sit there and not want to play. Like she also has autism. And prior to that, she would always take out everything in her room, the toys and so forth. And now she had no part of that. So that was when Dr. Wu had come up with another solution, because I was pushing more surgeries, and she's already had 3. And so they weren't going to go back in unless we were pretty sure we had a good focal point. And we just didn't with Shae. So Dr. Wu had told me that there was a new neurostimulator. It's not really new. It's been used for Parkinson's, but it is called DBS, and it was just recently approved for those who are 18 and older for epilepsy. And so, of course, my answer was an easy yes. I am for any, I keep my eye on anything that might be available for Shae without going with more medication. I think she's pretty much at the peak of where she can handle any more medication. So we did the DBS. That was that surgery was a little bit more involved. It was an all-day surgery, and it did require 1 night in the ICU. They insert leads into some tiny burr holes, and through there, the next phase of the surgery involves grabbing those wires and then attaching them to a generator in her chest. So she currently has the VNS still, and we still use that, and that's on her left. And then we have the DBS generator on her right. And between the two, she has really gotten some relief. The graph that is up there just shows her progress. She has had moments where they peak again, but we're definitely on a downward trend. And if you look at where she was 1 year ago compared to where she is now, it's about a 70% decrease in her seizures. And so my hope is to continue in that direction. And eventually I would love to decrease even more medication for Shae, just to get her out of the fog. She definitely is not spending her days sleeping anymore. Along with that, the behaviors have increased a bit just because she has the energy to do these repetitive behaviors now, but I'll take that. She's participating in life. She was always very underweight, and for once in her life, she is eating and gaining weight and enjoying her meals. And that's really important. So I think overall, she's gotten a much better quality of life through this, and I couldn't be more grateful. So both the VNS and the DBS, that has really helped Shae, and I couldn't be more thankful for that.
Wendy, that's fantastic. You really are a great spokesperson for, for all of this. You know, I think so many families are so scared of the idea of invasive, you know, forms, but I tell you, I would love to see my kid come alive more.
Yes.
And I think all of us feel that heaviness of our children being so drugged.
Yeah.
So I think it's really important for all of us to learn more about these, you know, different options that are out there for us. Yeah. So thank you for sharing, Shae, with us and your story. So now I want to take us back to introduce our next two members of our panel today. So Joyce Wu is section head of the Epilepsy Program in the Division of Neurology and the Lorna S. and James P. Langdon Chair in Pediatric Epilepsy at Ann and Robert H. Lurie Children's Hospital, Chicago. She's a nationally recognized for her expertise in research in tuberous sclerosis complex, which is what Shae has, we heard about. And she is the chair-elect for the Tuberous Sclerosis Alliance Clinical Research Consortium, and also well-known, I was checking on your publications, for using this novel EEG technology to detect high-frequency oscillations, these biomarkers in childhood epilepsy, to improve the outcomes of surgery. So really exciting stuff. I'm always so impressed when I go and look at all of your publications, everybody. We also have Dr. Sandi Lam. She is the division head for neurosurgery, also at Lurie, and professor of neurological surgery at Northwestern University Feinberg School of Medicine. Dr. Lam is a pediatric neurosurgeon and a leading specialist in the areas of pediatric cerebrovascular surgery. I'm not even smart enough to say the name. Epilepsy surgery and craniofacial surgery, with a focus on really using a lot less invasive technology. So we're really excited to pass it off to you and hear about your experiences and expertise. So I'll just one more note I didn't say in the beginning, if you have questions or at all, please feel free to get them going in the chat and the Q&A, and we'll pick those up at the end unless there's something that's really a clarifying question. So off to you all. Thanks.
Thanks for the introduction. I think I'll start, and then Dr. Lam will jump in at the different points as we go through the talk. And I want to thank Wendy for, again, sharing the story of Shae. I've known Wendy and Shae for, I don't even remember how many years. And some of the stories certainly was during my time. And I think some of the story of Shae was before my time. So it was actually pretty illuminating hearing the part that I didn't know about. So I definitely remember Shae being very sleepy and drowsy, and yet having lots and lots of seizures that she just couldn't sleep. And so it was very rewarding for me to see that Shae is definitely picking up and learning more skills and being more interactive, and hopefully with the help of my colleagues at UCLA, hopefully Shae can be even more alert and interactive and active when the meds slowly taper off. So let me, oh, that's right. I cannot advance the slides. Thank you, Sandi. So I just wanted to start with a little bit of a background, and this is probably not news to most parents, but just in case, just to bring everybody onto the same page. Epilepsy certainly is a big health care issue, not only in the US, but certainly worldwide. It's actually quite common. So here, I want to just relate to you that anywhere from 5 to 10% of the general population will have at least one seizure during their lifetime. And that, again, is quite a lot. Sorry, that's my beeper. When it comes to epilepsy, which is really just 2 or more unprovoked seizures, that is a very clean definition of epilepsy. When it comes to epilepsy, then 1 in 26 individuals will have epilepsy in their lifetime. And then anywhere from half to 1% of the general population, again, will have epilepsy at any given point in time, or about 40 million people worldwide. Certainly a lot of people. Next slide. And the other thing to remember is there's lots of organizations looking at epilepsy, including the World Health Organization, which found that 1% of the global burden of disease is epilepsy. And this part is surprising to me, that it's equivalent to breast cancer in women and lung cancer in men. Maybe not the same degree of recognition and funding to better study epilepsy. The other study to note, this is a purely US study from the Institute of Medicine that was done in 2012. Again, in line with that 1% of the general population having epilepsy, with 300 million people in the US population, 3 million have epilepsy, and 1 million have pharmacoresistant epilepsy, like the one that, like Shae, that Wendy just described, having been on quite a number of medications, whether at the same time or in the past. Next slide. And so that was 2012 for the Institute of Medicine study. In 2000, when this Kwan and Brody paper came out, which is cited quite a bit from everyone in the epilepsy world, we actually already saw what happened with new onset epilepsy patients. And this study really spanned about 14 years, and this was in the UK. And so we knew in 2000 that the first medication was able to get about half of the patients seizure-free. By the time you have to try the second medication, when the first medication doesn't seem to do the trick, we're down to the teens. By the time we get down to the third medication, we're down to single digit. Just like Shae, multiple medications at the same time maybe improves it quite by a little bit, but still in the single digit seizure freedom rate. And that again leaves us that number of about 1/3 not seizure free. And so what do we think in 2000? I remember that was exactly when I was transitioning from child neurology residency training to pediatric epilepsy training. And lots of my attendings thought, well, when this study came out, you know, again, it was 84 to 97. Perhaps some of the newer medications really haven't been included, and perhaps the newer medications could do the trick. Next slide. And as we see here, this is really a pretty exhaustive list of all the medications that have since been approved by the FDA and now on the market, and the year that the FDA approved each of these medications. And so since the 90s, certainly there were a ramping up of medications that continue to be approved by the FDA. But as you can see, even with the Institute of Medicine study at 2012, a lot more medications got released, and yet that medically intractable rate or pharmacoresistant, or just the fact that medications are not controlling the seizures, remained at 1/3. Next slide. And so besides the seizures themselves, which can cause injuries for sure from the seizures themselves, what we want to think about and keep in mind and certainly worry about . Can you guys still hear me?
Yes.
Oh, strange, the slides disappeared.
We have the autism slide up with Time Magazine.
Okay. So what we want to also keep in mind, and certainly as much as possible, prevent from happening, is not only the developmental delay that you see in the upper left side of the screen, but also the highly correlated autism, especially in tuberous sclerosis complex. And third, but not not the least, is the sudden unexpected death in epilepsy. And the more we go, the longer we go with uncontrolled seizures, the more there's a cumulative risk for SUDEP, or sudden unexpected death in epilepsy. So all of these, as pediatric epilepsy specialists, we very much keep in mind, and we very much want to prevent. Next slide.
We've got the epileptogenesis timeline up.
Great. And so this is a thank you for filling me in since I'm operating in the blind here. This is a very simplistic timeline. So when a child presents with seizures or epilepsy, the first thing we want to know, not only to treat it, to try to stop it, but also we want to know what is causing the seizure or the epilepsy. And, again, as much as possible, we want to control the seizures or the epilepsy. When the first medication doesn't do the trick, we switch to the second medication. And by the time the second medication also doesn't seem to be doing the trick, we've technically are at the third block there, where it's medically refractory epilepsy. And that is really the point that we really, as pediatric epilepsy specialists, need to consider. Are there alternative therapies, such as diets, some of the stimulators we're going to be talking about for the rest of the time, as well as resective surgery. Next slide.
So this is where's the seizures focus and where to avoid. I don't know if, Sandi, maybe you want to stop sharing and try starting again, if we could get Joyce able to see them again. I'm not sure.
Sure. Should we take a small break? Okay. So yeah, we're looking at the where's the seizure focus slide. I'm gonna share screen.
Oh, yay! Now I can see it. Thank you.
Thanks, Andy.
Okay, so in terms of then surgical considerations, what perhaps some or many of you have heard some of these words and terminologies. And so basically when we talk to the parents about surgical considerations, we, again, are keeping multiple things in mind. So first we want to know, where is the seizure focus? Where is the seizure coming from? And in order to figure that out, there's multiple tests that we could potentially utilize. And often the first one is the video EEG. We look at both the background, that is sort of second to second, minute to minute background that we see just with the child sitting or resting or standing. So that's the interictal background. What we also want to know is, when the seizures happen, where are the seizures coming from in terms of which part of the brain, whether it's the right side, the left side, is it the front part, is it the back part? And the third thing that we pay attention to is what is actually happening during the seizure, because oftentimes they will give us a clue as to where the seizures may be coming from that might differ a little bit from the EEG during a seizure. MRI is certainly another mainstay of this surgical testing, and both the video EEG and the MRI are non-invasive. The third one, at least at UCLA and at a lot of other centers, then is the FDG PET, or the fluoral deoxyglucose positron emission tomography, a big word and a whole mouthful, so we just say FDG PET. And that's the third way to look at the brain. So the video EEG is the electrical activity of the brain. The MRI is what the brain looks like in a picture form, right? And the FDG PET is sort of what we call functional test, because the glucose that the brain uses is weakly radioactively tagged, so that we can look at where the abnormalities might be in the brain. And that helps us figure out where the seizures may be coming from this FDG PET, as well as perhaps how big that area may be. Some of the other centers may use SPECT, or that single photon emission computed tomography more often, or just as much as the FDG PET. That is oftentimes an institutional choice. And there are certainly centers that use SPECT exclusively as the first round of testing. And the last one on that left side, the left column, is MEG, magnetoencephalography, which is very simplistically kind of a souped up EEG, if you will, a super EEG. It gives you the electrical signal, but it also allows you to put it directly on your child's MRI, so we know exactly where the signal is coming from which part of the brain. So all of those are potential tests you might hear about or have already heard about for surgical considerations. And the other side, on the right side, is where do we want to avoid any kind of surgery? And so anything that is listed there, the language, the sensation, the motor ability, where the vision is represented in the brain, all of that we want to preserve as much as possible. And there's sort of a picture of where these areas might be. Next slide. And a bigger picture, if you will, of, again, where these important locations that we want to preserve may be located. And the reason why I am sort of spending 2 slides on this is, gosh, if we can find an area of the brain that is very specific, and we know we have great confidence in, if we can resect this area, the child is more likely to be rendered seizure-free. That would be the first step. And then the second step is it close to any of the important areas, or is it part of any of the important areas? Because that may very well change our surgical thinking. And so if the area or the target is not close to these important areas of the brain, we often will elect to resect that part of the brain. If the area that we think is the target is close to or part of this important area, then we may not want to resect that because we don't want to give up that important skill that your child has. And that's where some of the brain stimulation comes in. And let's say if we cannot really say, gosh, you know, is it from the left side of the brain? Is it from the right side of the brain? If we cannot, with good confidence, say which half of the brain it's coming from, there's sort of a third group of patients that could potentially benefit from a brain stimulator. Next slide. And so we are, even though the title suggests we're going to talk about VNS or vagal nerve stimulator, next slide, and the following one. We are actually going to expand the topic a little bit and talk about DBS that Shae also has, the deep brain stimulator that Wendy mentioned, as well as the responsive neurostimulation, actually that is a typo, responsive neurostimulation or RNS. And to not confuse you, we're going to go through each device one by one so that you understand each one before we move on to the next one. Next slide. Okay, so we're going to start with the vagal nerve stimulator or VNS. There's a picture of where that stimulator sits, and Dr. Lam will go through more detail in terms of how that stimulator is placed and implanted. But for this slide, let me go through some of the background for VNS. So this is the oldest neural stimulator that we have available. So it was actually approved by the FDA all the way back in 1997, so 23 years ago. So lots and lots of data, very well proven, very well shown to be safe. When that was approved in 1997, it was approved down to the age of 12 years. And subsequently to that, there were more studies that came about so that FDA approved VNS in 2017 for age 4 years and older. All of these stimulators have a battery life. And so for the VNS, it's about 5 to 10 years, all depending on how much usage we program it for. And so if it's not a high setting that a particular child needs, that battery could definitely last longer than a child that needs more stimulation. And in general, again, lots of studies have been published. In general, we say about 50% of the kids with VNS have a 50% or more reduction from their baseline seizure frequency. And this is at 24 months, and that is an important point because at the beginning, you may not see the benefits right off the bat. It does take time, and there is a cumulative effect. The longer you have the VNS going, the more benefit the child will start to pick up. And so that's why that 24 months is an important distinction. Some of the other things listed here, again, because it's implanted outside of the brain, it's actually able to stimulate in a broader network and a presumably epileptic network versus targeting very specific areas. And that's a plus. And so we generally think of VNS for generalized seizures, or those seizures that you cannot tell whether it's coming from the left side or the right side. It looks like it's coming from all of the brain. Sorry, go back one slide, thank you. Able to deliver stimulations throughout the day. So basically, once the device is put in, you see your neurologist or epileptologist, and we program it as if it's a medication. And we think of it as a medication, meaning we, just like a medication, we start low and we'll go up slow. And that's exactly what we do with the VNS programming. And once it's programmed, it will go off periodically throughout the day, depending on how close we program the stimulations to go off. There is a way to do automatic titration now on the newer models, meaning we can say in 2 weeks, go up to this setting. In 4 weeks from now, go up to this following setting, so that you, as parents and patients, don't have to come back as frequently as before. The newer model also has this auto stimulation feature, which will detect your heart rate and basically stimulate or go off and get activated so that it delivers a stimulation without the magnet, because otherwise a parent would have to deliver that if it happens to lie outside of the already programmed stimulation. So this one detects the heart rate and delivers a stimulation. Like Wendy mentioned, there's a magnet that is associated with the VNS, and you can, if the child is having a seizure, the parent or patients themselves, if they are able to react fast enough, can actually swipe the magnet over the stimulator, and that also triggers the VNS for a stimulation. The good thing about VNS is it is MRI compatible. So once this device goes in, it does not mean you can no longer have MRI. In fact, you can. Initially it was with the 1.5 Tesla MRI. It is now also compatible with a 3 Tesla MRI, or the stronger MRI. And that also depends on the VNS model that your child may have. Next slide. Okay, so this is the initial study that came out in 1998 that basically allowed the, gave the FDA enough data to approve VNS as the very first neurostimulation device and adjust some of the data. It was almost close to 100 patients, even though the age range did dip down to the pediatric range, 13 to 54. Predominantly, it was actually adult patients. And there were 2 parameters, the high stimulation and the low stimulation group. And as you see, the high stimulation group actually benefited more with 28% seizure reduction compared to the 15% seizure reduction for the lower stimulation group. Next slide. So this is a study purely in kids, just because, again, insurance was giving us some issues in terms of you're not, 12 or older, and we really wanted to try to see if the younger children could also benefit from this, and the pediatric trial was important. This came out in 2012, and it was a randomized blinded controlled trial, exactly what we want in terms of the data that we want to give to the FDA so that they can improve it. This trial is a little bit smaller in terms of 41 kids, and it went down to 3 years, 10 months of age at the time of VNS implantation, and all the way up to almost adult age. And for this study, about 26% or a quarter of the kids had 50% or more seizure reduction compared to their baseline seizure frequency. And interestingly, at least for this study, both between the high stimulation and low stimulation, that did not seem to make a difference. However, that was in the short term. I believe in the long term, that cumulative effect or that cumulative benefit from the VNS did emerge. Next slide. And this one, I chose to share this one with you as well, because this is the, again, at 24 months, one of the largest studies in kids with VNS. And this came out of the European group. The age range actually went down to 3 months, which was surprising to me that it went down to that age, actually. And again, all the way up to almost 18 years of age. And they looked at 6 months, 12 months, and 24 months after implantation. And as you can see, there is that cumulative benefit with more time and more stimulation. Next slide. Okay, I will turn it over to Dr. Lam.
Thank you. All right. So, so I'm going to talk about how this vagus nerve stimulator actually goes in. So, for reference, the component is actually in the neck, and then there's the generator part that goes in the chest wall. So you can see actually in the neck, there's the vagus nerve, and then you'll see arteries and veins next to the vagus nerve. So that's why we actually have two incisions. One is actually to help get us to put the leads that look like little springs, actually, little coils that kind of go around the nerve. And then there's the component that will plug into this generator in the chest wall. So some of these scars you'll see kind of fade over time, right? So pretty prominent in the neck at first, but then later on in the neck actually will look like, in the same direction as the neck folds. Everything is under the skin, nothing is hanging out. And you'll see actually that there are differences in where people prefer to put the chest wall incision. That traditionally it's right under the collarbone. So you'll see a scar kind of on the chest wall, and some surgeons actually put it more towards the armpit area. So it'll be between the shoulder and the pec muscle. So there's different ways to kind of consider that. For me, over time, I've realized that the smaller the child, and the more thin the child, it's actually advantageous to put it under the pectoralis muscle, so you don't really see that outline of that generator in the chest wall. And also it kind of hides better, if you want to wear more like sleeveless tops also, and also that's kind of where your skin folds are. One more advantage is that some children may want to kind of pick at the generator over time, and if it's right under the skin, it may be possible to actually flip it and hurt the wires and the leads. But if you actually put it under the muscle in the armpit area and it sits under the muscle, it's actually not possible to be able to do that through the skin. So those are just some technical considerations for kind of like where to put the VNS for the most comfort and how things would heal. Typically this is actually very little blood loss, even though there are two incisions and they're next to a big artery and a vein. We know exactly where the big artery and the vein are, so we know how to avoid blood loss from them. A majority of the cases are done as an outpatient. So most, I'd say about 90% of the cases done in the country go home the same day, unless there's any issues with the breathing or the airway or anything like that. Most surgeons use sutures that dissolve under the skin. And then typically resuming daily activities is pretty soon, as long as it's within reason. And going back to therapies or school would be as tolerated between the child and the family. There is follow-up in clinic with VNS programming over time. As Dr. Wu mentioned, we usually start slow and then ramp up over time. Dr. Wu gave you a much more intelligent answer than the way I would normally think about it, which is I think about it like a radio or like music. You don't like turn it on full blast right away. You actually go like low and then figure out what's comfortable, and then you kind of dial it up over time. So that's how I usually talk with families to kind of talk about how long we think the battery might last, for how much you're using it, and Dr. Wu also mentioned that the 2-year time frame and really giving it time to see how it's going to work for each patient, and we typically don't think about taking this out, it's usually left in place, and we don't think about another surgery to remove it unless there's a specific reason to take it out. So now looking at kind of big data or real world data, this is what I'm going to show you next is actually how we came upon the rate of complications in kids. So when I looked at national US data and in our own practice, it just moved from Houston up to Lurie Children's, the rate of infections is about 1 to 5%, and this is in children. And if it is infected, it's a big deal because the VNS doesn't belong in the body, right? So it's actually very hard for an antibiotic to clear the infection. So we typically need to remove it and then treat the infection and then replace it with a brand new system if needed. The most dangerous complication is actually very rare, which would be actually bleeding or a really big bruise or bleeding that develops in the neck over time after the VNS is put in, that would press on the airway and cause breathing problems. That is very rare. And that's typically what we're looking for when you're in the recovery room until we know that it's safe to go home. Direct nerve injury and vessel injury is very rare. And then hardware issues, it is an implant, so it can break if unnatural things happen to it, like a big car accident or a big fight or something like that. And then the side effects that we hear about the most are either like a cough or like a tickle in the throat that can happen in programming and stimulation sometimes. And we can help mitigate that by starting slow. There can be also heart rhythm issues. We can typically see that in surgery when we put in the VNS, we turn it on and test it while we're under anesthesia and everything is all calm and controlled. So if there is on the very, very outside chance, I think it's 0.03% chance that there's any type of heart rhythm issues that is caused by a branch of the vagus nerve, we would know about it up front. And then the battery life is variable. All right, now we are up to the DBS, and Dr. Wu will summarize the next part.
Okay. So DBS, or deep brain stimulator, which is the second device that Shae received. Again, we as epilepsy specialists, we also tend to think of DBS similar to VNS, meaning if we are not able to say with high degree of confidence if it's coming from one side or the other, or generalized seizures, VNS is usually the first consideration. DBS is certainly another consideration for generalized seizures. So the FDA approved this device at 18 years of age, and basically as soon as Shae turned 18, we started to talk about DBS as an option. Battery life here is about 4 to 5 years. The median percent of seizure reduction from baseline at 1 year was 41%, as you can see on the slide, and there's also a cumulative benefit so that it actually rises to almost 70% by the time you reach 5 years. Keep in mind, these are all adult data. There's not really a good pediatric data at this time just because it's not approved for the pediatric patients. Again, the responder rate, which is another way of looking at efficacy or how well this device is working, is looking at the 50% or more reduction in seizure frequency. And so at 1 year, that's 43%, and again, it rises to nearly 70% at 5 years. What's also very important to note, which I always pay attention to, is seizure freedom, not necessarily just seizure reduction. And so it's really good to note that 16% of the subjects were seizure-free for at least 6 months. Again, some of the list, the things listed there, not limited to only that 1 or 2 focal epileptogenic foci. again, think of it as more for generalized seizures. Once we program it, it delivers stimulation throughout the day like VNS. The part that's in yellow is a little controversial. So the big clinical trial that was done for DBS was using the ANT, or the anterior nucleus of the thalamus as a target. There are some studies to show that perhaps another nucleus could be another potential target, but not as sort of proven in a large phase 3 multi-center clinical trial. Other things to note here for DBS, some surgeons like to see the MRI of the brain with the MRA and the MRV, perhaps not all surgeons, but some surgeons would like to see all the arterial and all the blood vessel information before the DBS is implanted. Again, this is also another device that is compatible with MRI. And the last statement there, in the trial with all the adult patients, they were actually programming DBS more frequently. And after the FDA approval, they actually started learning that, gosh, every 3 months or so might actually benefit the patients more. So waiting a little bit longer in between stimulations seems to be the better option versus, I believe they were trying to do it every month or so in the trial. Next slide. Okay, so this is the pivotal trial. It's basically called Sandi trial. You may see at the bottom of the author list that it's the Sandi study group, which basically stands for stimulation of the anterior nucleus of the thalamus for refractory epilepsy. So this Sandi multi-center double-blind randomized trial was actually performed in 110 adults, so a nice size. Again, all in adults, so 18 to 65 years of age. It is bilateral stimulation of that ANT, or the anterior nucleus of thalamus. And again, at 3 months, at the end of that blinded phase, when the patients themselves didn't know whether they were getting real stimulations, the seizure reduction was 40% in the stimulated group of patients versus 14.5% in the control group that never got the stimulation. So there is a significant difference between seizure reduction, seizure reduction between these two groups. And again, using 24 months as the important time point. 24 months after implantation, there's 56% median seizure reduction. And again, 50% or more seizure reduction, that also happened to be in 56% of patients as well. And 14 patients were seizure-free for 6 months or longer at this, for this trial. Next slide. This is then sort of the same cohort that participated in the trial, but this is their long-term follow-up. And so again, bilateral stimulation of the anterior nucleus of the thalamus. Median seizure reduction was 41%. This is where we got the almost 70% of seizure reduction at 5 years out after implantation. And again, there's that cumulative benefit of almost 70%. Again, at 5 years. When you look at it the other way, how many patients had 50% or more seizure reduction? Next slide. This one is the sort of the. I wanted to share this with you because this is the central median target. I won't spend too much time on this, but just to mention that you may hear if you go to your epileptologist or the neurosurgeon that sometimes they might want to consider the central median thalamus as the target, and there's some thinking behind, if you were mostly sort of bifrontal or perhaps Lennox-Gastaut, that maybe the central median target could be the better target, although again, not shown definitively, and we don't quite have the answer, and I think the jury is still out. Next slide. There you go. Back to Dr. Lam.
Okay, thank you. So yeah, so in thinking about the deep brain stimulation, this is another kind of, we're talking about basically neuromodulation, right? So as a surgeon, I would look for something in the brain that's just one area that's like guilty. It's like causing the seizures all the time, and it's somewhere that not part of the movement or the language or the visual centers, like Dr. Wu was talking about before with the map of the brain. If there's one area that's very, very defined, we do that type of resective surgery. If not, if it's from both sides of the brain or really in many areas of the brain, we have to think of how to tell the brain to calm down. And these are all, to me, different ways of us telling the brain to calm down. So, for the vagus nerve stimulator, we actually stay outside of the brain, right? So we go as far as the neck, but the vagus nerve actually has projections that are kind of widespread throughout the brain. Now, the deep brain stimulator is a different way to think about that. It's actually the thalamus, which is going to be our target here, actually has widespread connections as well. But this means that we're actually putting a stimulator or a lead into the brain and in through the brain tissue. These are the arrows kind of show us that the targets that Dr. Wu mentioned, so the anterior nucleus of the thalamus or the centromedian nucleus. And the other areas that are mentioned, like the subthalamic nucleus and the hippocampus and the cerebellum, are other areas that we talk about quite a lot in adult DBS for Parkinson's, or other areas that we think about in epilepsy surgery, like the hippocampus for memory or mesial temporal sclerosis. But the central median nucleus and the anterior nucleus of the thalamus would be the two targets. And really the goal of putting in the deep brain stimulator safely is to be able to go through the front part of the brain, so the top front part, and make it actually go very precisely into the target that we select, and do that safely without hurting any of even the teeny tiny blood vessels, because we do this through a hole and plan it with an MRI and imaging. We need to be able to do that safely. Then it will be connected to a generator that is implanted in the chest wall, like we talked about with the VNS, so similar area. So actually, in thinking about targeting, you may hear from a surgeon like different preferences or different ways. There are actually different ways of making sure that we're able to put the DBS lead into the brain, into the defined target safely and precisely. On the left side is actually a frame, a stereotactic frame, and that's the most kind of traditional way of being able to localize the target in space. Then you'll see that we do this kind of based on an MRI. And then actually have something affixed to the head to be able to target that. Then you'll hear about other types of technology. One is called a clear point system, which looks like a little rig that sits on top of the head during the surgery. And you can do that in real time in an MRI to be able to adjust the course while doing MRIs to make sure that you're putting this into the target. Then on the right side, you'll see something that we call a robot. It's not really the robot like it'll do chores for you type of robot. It actually is like it's a very clunky way to reproduce this frame on the left-hand side, but it can actually move in space relative to the head and hold a wire or a lead or any type of trajectory in space relative to the head to be able to use that MRI to be able to put it into 3D space. So these are all kind of different ways of all achieving the same goal, which is to put the DBS lead into the correct area safely. So the hospital course for a DBS kind of depends on the anatomy and the configuration of what we're trying to do. So if we're doing, both two-sided leads, and then some places will put the intracranial electrodes in, and then actually leave the leads kind of under the scalp, let everything heal, come back in a week or two and actually find the leads and put it, connect it to a generator in the chest wall. And some places will do that all in the same surgery. So wound care is really, really important, again, because any type of implant doesn't belong in the body. If the wound opens up and the implant can see the outside world, it means the outside world can see the implant, and it would be by definition infected. And we don't want any type of infected implant in the brain. So that's a really big deal. We'd have to take that out to be able to clear the infection. So with this, also outpatient programming over time, and for replacement of the generator, we'd reopen that chest wall incision, unplug the DBS leads and plug it into a new generator. So the side effects of this really kind of depend on the proper DBS targeting and really stimulating the exact area of the brain that you mean to. So in terms of long-term kind of safety and side effect profiles, there is really not large-scale pediatric data, so we can kind of infer from the Sandi trial data in adults, where really the most common things reported are pain at the implantation sites and tingling, which can be associated with kind of the areas of the brain that you might be stimulating. And then we talked about how infection is a big deal, right? If the implant site and the brain or the generator area, the incisions have issues, then the infection really needs to be treated aggressively. Then lead misplacement or migration, meaning that it would move over time or it was just put not quite exactly where it was targeted to go. Those are issues because then you're stimulating an area of the brain that would not be as effective for controlling seizures and may actually give you side effects that are unintended. Some are tolerable and some are not. And then lead fracture, if there's any kind of trauma or any issue with the lead as it traverses from the head all the way down to the chest wall. Any type of adverse events, especially those listed on the left-hand side, up to a third of patients experienced over the 5 years. So, we're really just wound care, good surgical technique, and making sure that, everything is cared for properly is really important. But keep in mind, this is the adult population, so we don't quite know for the pediatric population. We know kids typically heal quite well, but also with but children also have kind of thinner scalps, thinner skin, sometimes where we can have nutrition issues, and that can make it more challenging as well. So yeah, the biggest things from a surgical standpoint are really making sure there's no infection and making sure that the leads are placed correctly and safely. And now we're on to RNS.
Okay, so RNS. Responsive neurostimulation. And you might be able to see from the picture that it is placed on one side. And so one of the take-home messages is responsive neurostimulation is a little bit different than the prior two, the VNS and the DBS. If you are able to localize the seizures to a certain area of the brain, and yet it's because it's right next to an important area we don't want to remove. RNS is in general thought to be the best next option. So FDA approved in 2013. Again, for now, it's approved for 18 or older, but we've had some success in implanting some of these in pediatric patients younger than 18. And I'm not quite sure where Sandi was, how these patients were implanted when they were less than 18, but I think, at UCLA, our neurosurgeon basically really did it as much as possible for basically free. And so we basically beg and borrow to try to see if we can put the RNS in the younger kids. And the other important thing to note is that NeuroPace, which is the company for RNS, is definitely interested, just like VNS did. They're very interested in working with the FDA to lower that age range. So hopefully, in not too long of a time, we can lower that to perhaps 12 years or older. Battery life here is 8 years. Efficacy in terms of how well it works. The latest results that have been published actually shows quite a bit of seizure reduction. In fact, about 75% seizure reduction in the long term. And any kind of neurostimulation, like you saw with the VNS and the DBS, and same with RNS, there's that cumulative benefit. So at 9-year follow-up, there's a 75% median reduction. Certainly didn't start that high, but it got there eventually. At the time of this publication, at the 9-year follow-up, about a third of the patients with RNS reported at least one 6-month period with no seizures. So that's encouraging. I already mentioned this, seizure frequency reduction does improve over time. Let me see. This RNS is also different from the prior two devices in the sense that when the device is implanted, you actually get brain signals out. Whereas the other two, we don't see any brain signals. RNS is very unique in that you can put up to 4 different what we call leads, but basically electrode sets, and any 2 can be active. And you can actually read from those electrodes that are on the brain so that we can see and train the system. So that the first 3 months or so, we actually don't turn on the RNS. We literally look at what information do we get back, where are the seizures coming from, if there are seizures, and if there are seizures from a certain area but not from the other, we would basically program the device so that it targets that area with a stimulation, so that it's a few seconds into the seizure, we can turn on the stimulation, program it that way, and it'll deliver the stimulation and end the seizure. That's the goal. Let's see, what else? Again, similar to DBS, some surgeons, perhaps not all surgeons, will want to see an MRI and the MRV, again, looking at the arteries and the veins or the blood system in the brain to avoid those blood vessels. RNS just recently got approved for 1.5 Tesla MRI to be done. Just prior to that, we were not able to put someone with an RNS into the MRI. So I'm glad to see that it is now approved for 1.5 Tesla MRI. Because this is also unique to RNS, it does require the patient and the family to download all the recordings from the brain directly. There is a mechanism to store it, but once you get past a certain, there's only so much memory, right? Because if you want to store more, then it will need a bigger, either a bigger battery, longer lasting battery, or a bigger device in general. And so the family is, asked for their help to download all these recordings so the epileptologist can go over and look at all those so that by the time we want to program it again, we know which leads or electrosets to target, as well as which pattern may be emerging, and we want to target that pattern. Next slide. Okay, so this was published in 2011. Marty Morrell, or Martha Morrell, is a professor at Stanford who really is the brain behind RNS, and she published this seminal paper. Again, a clinical trial, multi-center, double-blind, randomized control trial, exactly what we want for the best evidence to show that this device works. 100, almost 200 patients, all adults with focal seizures. At the end of the 3 months, there was a 38% seizure reduction in the treatment group versus less than half of that, 17% seizure reduction in the control group. Next slide. This is the 9-year follow-up that I mentioned already, but this is so you can see where the the article and all the authors. This was just published earlier this year, in fact, last month. So at 9 years, the median percent reduction in seizure frequency was 75%. And again, I focus on seizure freedom. And so if you skip down a few lines, about 18% had seizure freedom for 1 year or more. And some patients have even more seizure freedom rate that's listed there as well. Next slide. Back to Dr. Lam.
Okay, yeah, thank you. So Dr. Wu had mentioned a few times the MRI and MRA. The MRA is an MR angiogram, or at least an MRI with contrast that will show you in detail the blood vessels in the brain. So if you look at this configuration of the RNS on the left side, where there's actually a lead actually going into the brain, that's typically how we decide if we're going to put something into the brain tissue. We want to be able to plan that and want to see the vessels clearly so that we can avoid them. And so that's how we kind of decide on the imaging that we need to do the planning. So there are a few components, and some of these neurostimulator components will start looking familiar, right? So there's always something that looks like a generator or a battery or the computer, if you will, and then these kind of stimulators or leads or electrodes. So, and Dr. Wu also made a distinction about what implants are approved by the FDA for what age. So I guess even when VNS was approved for 12 years old and above, there were exceptions or exemptions, you would call it, that are made where if a patient really needs it for a humanitarian purpose or because there are really no other treatment options, that we could think about this as an off-label use, where we would not advocate for an off-label use, but this would be on a case-by-case basis to help patients. So for the case of RNS, we've done it in pediatric patients. So really, if I'm thinking about an off-label use, which I'm not advocating for, but if it is if it may be very helpful to a patient, what I would actually look at is that you see here in these skull models, that the computer or the generator or the battery actually takes the place of the skull. And that's why it's actually not in the chest wall, it's actually in the head. So when we put it in the head, we actually have to take out a piece of skull that is in that shape of the generator, and we put the generator in and have that kind of recreate the skull. If you think of a very young baby, the skull is very, very thin, and almost like eggshell thin. So, in order to kind of replace skull with a generator that big, that will not work, right? That will stick out, it'll be a bump, and also the babies are still growing. So, in my mind, if you think about that as kind of a configuration challenge, any child that has a size of the skull that is close to an adult, and is thick enough to accommodate the generator, would be okay in that puzzle, even though that's not FDA approved. So by my measurements and what we've done in exemptions before, we've gone down to age 6 years or age 4 years, although that's not FDA approved and not advocated by the company. But those are kind of like the technical constraints that we're looking at. So here the stimulator you'll see is in the skull. You can have different configurations. One is the electrode, which goes on the surface of the brain. It lays on the surface, or a depth electrode where you actually put it into the tissue of the brain. So there's a reader that can kind of transfer data with the generator, and that will look like little EEG waves, if you will, on the physician tablet, and that is the data that you would be kind of uploading over time. So an example, I had talked about how to a surgeon, really, the ideal resective epilepsy surgery candidate, if there's one obvious guilty area of the brain that you don't really need for moving or talking or anything like that, that is causing the seizures, we take that part out. If the area of the brain that is causing seizures, we know, or we have a hypothesis or a guess as to where it's coming from, and it's kind of a defined area, but we can't resect it because we would hurt the patient's function. So if it's in the motor area where we need it to move or walk, or if it's right over the language area, where we would need to understand language or generate language, then we would think about, okay, can we stimulate it instead of taking it out? So this is an application of the RNS. So eloquent cortex would be anything that would do that we really need, like language or motor. And that, if it's on the surface, then we would think about the surface electrodes or the strip electrodes. So we would lay it on top. We can also have a combination of a depth electrode and a surface electrode, or two depth electrodes. And if you think about like a configuration, if you have this and this, and you're kind of doing the stimulation, the area of the stimulation is kind of between the two things that you put in kind of 3D space. Also, you're going to have a combination of resection, if you can actually take out an area of the brain that's causing seizures, but you're limited because you can't go any further, because you could cause a deficit like a motor deficit or a language deficit. You could resect the abnormal brain up to the area that you can't take out. Because of eloquence, you can actually stimulate the rest of that area. So it leaves some options for how that configuration can go. So in terms of the safety and the side effect profiles, these are from the adult clinical trials, because even though we've been doing this in children for about 4 years, there are no large scale pediatric studies. So from some of the studies that Dr. Wu mentioned, we know that that the safety is comparable, if not a little bit better than the DBS trials. And there haven't been any known cognitive adverse outcomes or any side effects from stimulation. And then the implant related infection rate is about 4% or 4.1% per procedure. And then also I had mentioned putting in the electrode and trying to avoid vessels. Every time you actually put in an electrode into brain tissue, that there is a non-zero risk of bleeding. Mostly, if we can detect the bleeding on imaging, on a scan, most of the time it is not a catastrophic hemorrhage, and it's usually a small area of bleeding along the insertion. And these trials, they did not cause long-term issues, but it's important to know that anytime we pass something through the brain, the hemorrhage rate is usually about 1% to 2%. So in these trials, it was 2.7% that they were able to see on imaging as well. So what does a hospital course look like? It really depends on the configuration, right? Like, you know, how we kind of like shaped the RNS and where we're putting it. If we needed to kind of open up and do a resection and then leave the RNS, or did we put in depth electrodes where those are more, the exposure is a whole, then you need the exposure that you take out that portion of the skull and replace it with that generator. So the typical hospital stay can be between 1 to 4 days is what I've seen in my patients, just kind of depending on how much surgery you had to do. The skull bone thickness does matter in terms of planning. Wound care is, again, incredibly important because it's an implant that doesn't belong in the body. So we have to make sure that it never sees the outside world, so that the skin has to heal over it very well. From a surgeon's technical planning, we generally try to have the skin incision, any cut, not immediately over the generator, okay? Which is why you may see kind of big curvy cuts that look bigger than the generator itself. It's because we actually don't want the skin opening to be right over that metal. So if it does open up, you won't have exposed metal underneath. There's the programming and the uploading of data that we talked about, and then replacing the generator actually means reopening that head wound. And the way that the way that we replace the generator means that putting it in and setting yourself or your colleagues up for success later on is really important. So if you think about having to open the head incision again, having the leads, any of those little wires and electrodes not right under your incision is very important so that we don't hurt them on the way in, but that they're still accessible to unplug from the generator and then plug into a new generator, and it sits again in that skull hole again. So those are kind of the considerations for RNS. There's different kind of options for how to configure those.
Okay, thank you for staying with us. I know we're running behind. So a quick summary then. About 1/3 of folks with epilepsy are medically refractory from medications alone. There are considerations and other comorbid conditions like developmental delay, autism, and sudden unexpected death from epilepsy that, again, we want to keep in mind as well as prevent as much as possible. When a child fails 2 or more anti-seizure medications, that really is a time to start thinking about alternative options like surgery and devices. And so just to reiterate what I've mentioned before, if seizures cannot be clearly localized or lateralized to one side or one hemisphere, or we usually think of those as generalized epilepsy, VNS, and or DBS, like in Shae's case, are both options. If seizures can be lateralized to one hemisphere, or we are able to say whether it's left side or right side, or focal epilepsy, but it is perhaps too close to the important areas we want to preserve, then RNS is a good option. So that, like Dr. Lam mentioned, we could certainly do some resection and leave the RNS for this stimulation of the important areas that cannot be resected. And I think I will end there. That is the last slide, I believe. Oh, yes. Thank you for listening. Your contact information and everything.
Great. We'll put that up there for folks to be able to grab from the website too. Thank you all so much. This is a lot of information, but I think for those of us that have joined and stuck it out, this is kind of what we needed, is kind of like, you can't do that in a 15-minute chat. We really needed that level of detail. So really appreciate it. We do have a couple of questions coming in. Hopefully people have time to stick around for a little bit longer. And so one of the questions was about, the summary slide helped us understand, generalized versus focal. Somebody was asking about migrating focal. Is that still a good RNS option?
Migrating focal, is that, if it's within, well, maybe I can answer it this way. So some patients do have more than one seizure focus, or two or more foci. If they're on the same hemisphere, and the surgeon can, put both, whether it's depth or strips, or, again, I mentioned 4 is actually a possibility, but only 2 are active. If the surgeon can put it in, then, and if the seizures are sort of within those 2, either strips or depths, then potentially that could be helpful. Because again, if we can stimulate across that entire brain area, perhaps that's an option.
Mm-hmm. Excellent, thank you. Yeah, and excuse me. I think that, did there tend to be camps of people that, like, some neurologists are really, hey, pro, these stimulators, or pro surgery, and others aren't? I mean, if you're not hearing about this from your neurologist and you think it could be helpful, do you bring it up? Do you look for somebody else? What do you see in the field?
So I think one of the reasons I think for webinars like this is to empower the families and the parents. So if you're not hearing this from your neurologist or epileptologist, I think you should feel more than free to ask about these other options. And, I know Wendy actually, before we were even talking about DBS, she came to me and asked about RNS. And actually, before I even knew that there was CBD trial going on, she already told me. And so parents like Wendy are great, keeps us on our toes. And so certainly when the CBD trial for tuberous sclerosis complex patients came about, she was the first person that's called me. And so very informed parents are always, I think all parents should be empowered to ask all kinds of questions.
Mm-hmm. Yeah, absolutely. And I think a lot of us learn pretty quickly that if you want something, you better ask for it. You can't wait around for people. So, Wendy is clearly a good model for that. Wendy, you talked a little bit about reducing anti-seizure drugs, right? Has Shae been able to reduce any yet? And I guess for Dr. Wu and Dr. Lam, is there any research on whether people are able to come off some ASDs as a result of these stimulators?
Yeah, so just like, I guess I people who know me, I'm a lumper, meaning I tend to lump all the different categories together. So any kind of surgery, whether it's devices or resective or ablation or, we always try to see what is the response, meaning if the seizures are starting to reduce, but not quite gone, or the seizures are actually stopped, they have stopped altogether. Definitely the next thing for pediatric epilepsy specialists to think about is, well, when do I wean meds? And do I wean meds? When do I wean meds? And then which medication to wean? And then how fast? Those are all sort of different versions of the same question. And so, yes, so the goal in my mind is always, can we, since these kids have already failed at least 2 medications, and after any kind of surgical intervention, if we are able to peel off one by one some of the medications, that is the goal. Have I had kids that went through some kind of surgical intervention and was able to come off completely off medications? Yes. Mm-hmm. Yeah, and I think more than a handful. And so I think that's good to know, and good for neurologists to know as well, even in TSC.
Mm-hmm. And Wendy, have you guys started any weaning yet, or attempting, or is that in the future? Oh, you're muted. Wendy, we can't hear you.
How about now?
Yeah.
Okay. Not since the DBS, but after the VNS. Once we started the Epidiolex and the CBD, and Shae became extremely sedated, was when we tried to, I wanted to hold on to the Epidiolex forever, but I wanted to give it a good, honest shot. And unfortunately, her current medications weren't letting us do that. So we did try to fool with a few of her medications, but seizures came back pretty quickly. And so that just wasn't a choice for us. One we did let go, Shae was on Lexapro, and that one wasn't necessarily intended to help her seizures. So we did let that one go. I think that did help, just having one less medication in there, but I do think that is a possibility to look at, because she is doing extremely well, surprisingly well. And I don't know if it's the combination of the VNS with the DBS, but she's definitely doing much better than expected. So that I'm hopeful.
It's amazing.
So yeah, and part of the VNS is actually, we still don't know exactly how it works. We know it works, right? In 50% of kids in a 50% kind of way, but we don't actually know the exact mechanism. So yeah. So in terms of, being at a place where are all treatments offered, or wondering if you should be shy about asking your doctor certain things, I think it's really important to us as providers that work with families, that we are continually questioning what we do in terms of, can we do this better, and how can we do this better? And until there is a cure, we can always do better. So we need to learn from each other. And Wendy, families like you and Gabby, you make us want to do better, and that's part of why I'm so proud to get to work with people like Dr. Wu, because we want to learn more, so that we can do better for your kids now, and then for kids in the future that we haven't even met yet. And that's why we do research, to see how we can do better. So we kind of do it in different ways, and we know that we don't have a perfect system yet, right? Which is why we're very I think in terms of especially surgery, it's very important to be honest about what we think we can do and what we can achieve and what we can't achieve, and what we can't guarantee. But I think it, as long as we understand what our goals are, we need to try. We need to try to do better. But that's why also in terms of surgery, safety is very important, right? We need to try, but we need to know that we can do this safely. And then have hope. So, and places that have higher volume, typically there's a volume outcome relationship, where if you do something day in and day out, there's some efficiency and quality that comes with being able to kind of deliver on that. So those are all kind of things that I would look for, and really have doctors that have an open mind. So I think somebody who's not willing to listen to you, I don't know, when I go to the doctor with my kids, I want my doctor to listen. And if my doctor's like poo-pooing me on something, like I would feel dumb. But then I also feel like, I wasn't listened to. And also like, wait, did they really understand what I was trying to say? So I think all of those things, it is our privilege and our honor to be able to work with you guys.
Well, we are so lucky to have, I feel so lucky because with DEE-P, we get to bring in like the best of the best. And so it's always really exciting and inspiring. And it did come up in my mind, and as somebody else wrote it as well, that the 1/3 of cases where there are, severe, or what's the, there are severe
adverse, some sort of adverse event.
Right. Some of which are pretty serious. Does that feel high to you, or are like the large majority of those adverse effects kind of manageable? We figure it out.
So that part is a little bit harder for me to interpret, because this was an adult population, that is kind of different than kids a little bit. Their skin heals differently, their tissues heal differently. And the patient population is a little bit different. I know that when I send a child home with their parents, that wound is going to be washed and going to be very clean, and everything is going to be perfect. In all human possibility. I think the adult population is a little bit different, in terms of care, in terms of kind of size, in terms of independence. And since wound care is so important. And also I think the lead targeting was an issue, right? We saw it was at least 8% of them were off in terms of the targeting, and then some migrated over time. And also the fracture, right? So that if a lead is broken, did somebody fall? Adults have a longer way to fall. I guess, can you get in a fight? Yes. But all the targeting, I think we've gotten a lot better over time as well. In the past decade, we have more technology, we have more understanding, we have just better ways of targeting all around. So I think yes, that is an unacceptably high rate. Does that mean we should give up? No, but it is DBS like the best in young kids that are growing? Probably not, right? Because we have to account for growth. So but does that make us extra obsessive compulsive when we do surgeries with any type of implant or hardware? Yes.
Yeah, and I think that's so critical, is the having opportunities to learn, right? If we're not tracking what's happening, we're not going to learn, and we're not going to get better. And so we're really grateful to centers like Lurie that are really committed to that. And I think that's, it builds more confidence for the families. And I'm really excited about having this be a resource up for families to go to, because I don't think this gets talked about enough. And so, a lot of people have heard VNS, like, what is that? Or, DBS. And so I think this is a really fantastic way for families to kind of get a better feel for all of these things. So I know we're stretching times here, but are there any final thoughts any of you want to share, Wendy, on your experiences? You wouldn't go back on either of them? Good decision?
Absolutely not.
Yeah.
Yeah, absolutely not. I've always been one, for technology and research and new things to try. And although, like you mentioned, it could be risky at times, I think it's worth it. I think life is worth it. Quality of life means a lot.
Mm-hmm.
So it's not always, I think it's an important balance, right? I want Shae to be safe and not just have some dangerous seizures, or even like Dr. Wu had mentioned, SUDEP, which is a real danger. But at the same time, I don't want to over medicate her, and that's no life. So yeah, and I'm just very thankful that at least the doctors that I've worked with are very open to listening and will tell me their opinions. I wanted surgery and that wasn't going to happen for Shae. So we found something else, and it's working really great. So I'm just grateful. Yeah.
Terrific. Yeah. And are there any studies that say, it's hard to measure missed, SUDEP, but are there any studies that show that populations with, these stimulators may have reduced, SUDEP rates?
There are, I think the RNS study actually isn't published yet, but it's been submitted, that the rate of SUDEP is lower in the implanted individuals. But it's not out yet. And actually, we've been working with national VNS data, and that's actually one of our preliminary findings as well. That at 2 and 5 year follow up, the rate of death from all causes is lower in the kids that are implanted versus not. That's not published data either. And then, so I'll actually share my screen for one more thing, which kind of summarizes or speaks to just kind of surgery in general. When we look at national data, when we look at kids who are with refractory epilepsy who are treated medically or medically and surgically, and we match the children by age and diagnosis. If you just follow this, and when Dr. Wu told me she's a lumper, this was kind of what I was thinking about. When you lump kind of kids in the same trajectory who have failed multiple medications and are continuing to seize, when you look at at what happens at 2 years and 5 years, when you follow these kids forward, survival is actually higher in the kids who underwent surgery. And then when you look at kind of quality of life and kind of the journey, going to the emergency room, being admitted to the hospital, all of those epilepsy-related events were lower in the kids who had surgery as well, and then over time, when you track their prescriptions, there were fewer anti-seizure medications used in the in the surgically treated group compared to the medically only treated group. So so over time, I think really initiating those conversations about talking about surgery and if those are options, I think are very worthwhile.
Yeah, excellent. Thank you for sharing that. That's actually a really fantastic visual to see, some of those really tangible results. So, well, thank you so much, everyone. I just want to quickly, and thank you everybody for hanging with us. I think it's a testament to how informative and fantastic you all have been as in sharing this information with us. So we're really grateful to our guests. And thank you for sharing your stories and your experiences and your expertise. We do have another webinar tomorrow on SUDEP with Bill Gaillard. He's the president of the American Epilepsy Society. Elizabeth Donner from Sick Kids in Canada, who's an incredible advocate for families hearing about SUDEP. And from the Danny Did Foundation, Tom Stanton. So we're really looking forward to that. And, we want to thank Neurocrine for their support in helping us get some of these webinars up and running, and to all of you. So again, thanks to everybody. Thank you everybody for sticking around and listening in. And, we'll continue to, we'll get this webinar posted, and we will add a bunch of resources. Hopefully, if anybody has resources they want us to get up there to help better educate families about this. So let's see, just see someone here. I think this is a great opportunity for me to restoration and know. Okay, terrific. I'm so glad, Kelly. All right. Well, thanks everybody, and have a great evening, and we'll see you next time.
Thank you.
Thank
Bye-bye.
you.
Bye.